All right, very good. Okay. All right. So today we will be talking about this. What is the best way to deal with a diabetic patient on the first visit? So, what is the appropriate physical exam and screening? As endocrinologists, we are focused on diabetes when we are seeing these patients. So, we have a little bit more time than some of the primary care physicians, but I want to give you an effective way of how to deal with these patients when I'm seeing these patients. And this is based on the recommendations from American Diabetes Association. All right. Next slide, please. All right. Very good. Can you click a couple more times so that we can see everything on this screen? Yeah. One more. Okay. Excellent. All right. Oh, all right. That's fine. So I will start with a case. It's a typical case I think I saw about 3-4 months ago, this patient. So, he's a 48-year-old male who was sent to me because of diabetes. He has, according to him, diabetes for the last 5 years. Um, and also has the hypertension along with that, around diagnosed around the same time. As you can see, he's a little bit obese. His BMI is 34. He reports that he has a desk job, so he's not very active. He does not find time to exercise and stuff. Medications, typical medications for a diabetic, lisinopril. He does not know the dose of lisinopril. He said that it was just given to him for kidney protection. He takes a big pill of metformin 2 times a day. It's one gram, and he takes glimepiride 4 milligrams. So again, a standard treatment that we commonly see. Does not smoke and drink. When we look at the BMI, it's 36. His blood pressure in the clinic is a little high, and A1C is 7.8. He does not check his blood sugars. There is no subjective hypoglycemia during the day. His cholesterol lipid profile done about 3 months prior to this visit. His LDL was 134, total cholesterol 220, and his HDL is 34. So what is our next step in this patient? So this patient is sitting in front of us. This is the information. So what do I think when I see these patients? Next slide, please. All right. So again, the most important thing here that I feel is that we should think about, diabetes is more than just elevated blood sugars. It's a disease that can affect any organ, and this disease works in a binary fashion, meaning, for example, it can increase your risk of obstructive sleep apnea, the diabetes by itself. And then if you have obstructive sleep apnea, then it will increase your resistance overnight, insulin resistance. It will increase the stress hormones and will make diabetes worse. So we have to not only focus on diabetes, but the person as a whole. So these are some of the organs. I'm starting from the top and going down that diabetes can affect. And then these diseases in itself can affect the diabetes. So if you have a stroke patient who is losing muscle mass on one side of the body, his or her blood sugars will run high because he's losing muscle mass and gaining fat most likely. Similarly, dementia. Diabetes can increase the risk of dementia, and dementia in itself can make the diabetes control a little bit challenging. Similarly, depression, mood disorders, we know all chronic diseases can increase depression. Diabetes is no exception. And then depressed individuals, their stress levels are high and diabetes will get worse. Eye disease, all sorts of eye problems can happen with diabetes, from dryness of eyes, just non-specific complaint, to cataracts, to bleeding and blindness. Very unrecognized condition, and I think we should focus on this in a diabetic, is the gingivitis or dental problems. Inflammation, gingivitis, any kind of inflammation, as we know, any kind of infection, smoldering infection can make diabetes worse. And periodontal disease, gingivitis can make diabetes worse. So if the patient has not seen a dietitian, dentist in a long time, that is something we should focus on. Heart disease, again, that's, we know the macrovascular complications of diabetes. Sleep apnea, I already mentioned. Fracture risk. Fracture risk is also common in diabetics, especially because it slows down the bone remodeling. And some of the medications, especially the oral hypoglycemics, can increase the risk of osteoporosis as well. Actose is one. Some of these SGLT2 inhibitors can also cause it. So we have to take this into consideration. Fatty liver, because of insulin resistance, there's more, and high lipids, it can cause diabetes, can cause fatty liver. Fatty liver liver will make the control of diabetes difficult. Pancreatitis, about twofold increased risk of pancreatitis. If they develop pancreatitis, their pancreas will be inflamed and damaged, and then the diabetes, the vicious cycle will just continue to get worse. We know about the increased risk of infection. Cancers, endometrial, breast cancers are elevated. The risk, and pancreatic cancers are higher compared to in a diabetic compared to a non-diabetic. So that is also something that we need to keep an eye on. Joint problems. This is also very common, and we see this all the time. And I have a few pictures which we will show. Frozen shoulder is extremely common in diabetics. Arthritis, and I will show you some pictures. The limitation of hand movements, and again, if they have to inject insulin and their hands, the dexterity is an issue, then it will become a problem. So those are some of the things that we should keep in mind in these patients. Next slide, please. So I'm talking to this patient, 48-year-old that I presented. These are the few things that I quickly want to make sure that I have talked to them. Number one, the age of onset. How long they have had diabetes, and what was the initial presentation? Were they sick and in the hospital, or was it just an outpatient screening kind of workup? How high was their blood sugar at the time? Some patients present with a blood sugar of 600, 700. Were they in ketoacidosis at that time? So this will, if they're very high sugar and they were not in ketoacidosis, then this means this is most likely not type 1. Were they losing weight? The classical presentation in type 1, which is they're drinking a lot, peeing a lot, losing weight. Do we have that presentation or not? I want to know their medications that was started before they presented with diabetes. Steroid injections commonly elevate the blood sugars, especially if they had a couple of injections. Immunotherapy, now we are seeing more and more of these new cancer medications which are causing diabetes. So I want to know if there was something started. Transplant patients. Transplant is commonly associated, bone marrow transplant, renal transplant, liver transplant, because of insulin resistance, and sometimes these treatments include steroids by itself. Pancreatitis, similarly, they had a gallstone attack and they developed pancreatitis that damaged their pancreas, and then what happened? So these are the things I want to know from the patient. When was it diagnosed? How was it diagnosed? How high was the blood sugar? And so on and so forth. I want to review the previous treatment regimens that the patient was given. If they have already failed a medication, there are a lot of patients who tell you that they were on metformin, they developed horrible diarrhea, they don't want to start it. So if you want to start metformin in this patient on the first visit, that's probably not a good idea. Maybe sometime later down the road, you can try that. So you ask side effects. What exactly happened? And at what dose, if they remember the dose. And any hospitalizations with high sugar, low sugars, and if so, how often has that happened? So how much is their quality of life affected by uncontrolled diabetes? So those are some of the things that I want to gather when I'm taking the history. Next slide, please. This is, as you know, family history is very important, especially in the first degree relatives, in their parents. Also history of obesity, their lifestyle, and not only diabetes history, but if there were any complications from diabetes. We know some people will develop neuropathy at an early stage of diabetes. Some people will develop eye disease in spite of the fact their control is not that bad. And this also genetic predisposition. So if their dad had diabetes, how bad was it and what kind of complications? Were they on dialysis, for example? Blindness, amputations. I want to know diabetes and exactly what happened to their diabetes. Autoimmune disorders, diabetes, any endocrine disorder can run together. So history of thyroid disorders and other autoimmune conditions. I want to know lupus and other things, other autoimmune conditions, pancreatitis, autoimmune liver problem, so on and so forth. Next slide, please. I want to understand the patient who is sitting in front of me. So I want to know what is their lifestyle like. I can give them a plan, but will that work with their in their lifestyle? So I want to know their eating pattern, their weight history. Have they been progressively gaining weight? Is that bothersome to them? Do they want to lose weight? What kind of work they do? Are they awake all night? What is their sleep pattern like? Are they snoring most, for example, at night? Are they active? Their lifestyle. Of course, we want to know if they are they're smoking, using alcohol or any other substance use. And especially for type 1, I want to know, I want to feel how much they understand about carbohydrates. Do they know which food has a lot of carbohydrates? What should they not be eating? And what kind of a social support system they have? Are they depressed and without any help? Do they know where to go for help in case they need help? Next slide, please. Vaccinations. This is important, but I want to know their medication tolerance. So the other medications that they're taking. For example, this patient was taking lisinopril. He didn't really know the dose of lisinopril. So is he really taking it? Is he getting his medications filled? So that is important thing. Are they using any alternative medications, any herbal supplements, those kind of things? We need to get this information too. And vaccination. So this is important, and this is American Diabetes Association recommendation. Of course, we know flu vaccine every year in the fall is indicated. The pneumococcal vaccine, pneumonia vaccine is indicated for all diabetics between the ages of 2 and 64. After the age of 65, regardless of whether they had taken the pneumococcal vaccine or not, we should repeat it one more time. So pneumococcal vaccine twice, once between the ages of 2 and 64, and once after they are 65. So if you're seeing a 66-year-old who has received pneumococcal vaccine, the vaccine is due. Hepatitis vaccine is indicated if they were not being vaccinated, especially if they're between the ages of 19 to 59. Even after that, you can consider giving it to them. Now, this is one important thing. There was a lot of back and forth about the Prevnar, the PSV13 vaccine. In 2018, the ADA has recommended not using the Prevnar vaccine and just the pneumococcal vaccine. So if the patient is in the nursing home, then maybe the Prevnar, which is the PSV13, can be given because they're of their increased risk, but not needed at that time. Next slide, please. All right. So you're seeing this patient, you want to know if they have developed any complications from diabetes. And these are the few things that I want to discuss with them. This will help us in the long term. Do they have any complications like macrovascular complications? So those are the stroke, the peripheral vascular disease, or heart attacks. Have they developed any complications? Macrovascular. Microvascular, this is your retinopathy, neuropathy, and nephropathy, kidney problems, nerve problems, and eye problems. So I want to talk to them about it during the first visit, and also on each annual visit. So this is something that any change, any strokes, any heart attacks, any stents in the peripheral circulation. I want to know about if they have any sickle cell disease or any blood transfusions, because that will affect the A1C. So A1C will become unreliable if they have had these blood transfusions, for example. So A1C will look falsely normal because of the blood transfusion. We want to check blood pressure. We want to see if they're checking blood pressures in their home environment on each visit, initial visit, follow-up visit, annual visit. We need to know what's happening to their blood pressure at home. Lipid profile at baseline and every year for the same reason, because lipids, if we control it, then we can prevent some of the macrovascular complications. I already highlighted the importance of dental exam and see if they have gingivitis or any inflammation, and then they need to see the dentist for. We all were very familiar with the dilated eye exam. We normally do if we can do a fundoscopy, we can do it in the clinic, but these patients need to see the eye doctors every year just to make sure that there is no proliferative retinopathy. Next slide, please. So these are some of the screening things that I have in mind when I'm seeing these patients. Number one, for example, I want to know if they have already seen a dietitian, if they have already established one and they know what to eat and what not to eat. And if they have not seen one and their information about carb intake and what to eat is lacking, then I'll probably discuss this with them if they need to see one or provide them with some material. There are some resources that we normally hand out to patients in the clinic. online. If they are technologically savvy, then we can give them the web addresses which they can read themselves if they don't want to go and see the dietitian, because that is a very important piece of treating their diabetes. I want to know about their hypoglycemia, how often they are having them, and at what numbers they can feel a low blood sugar. Hypoglycemic unawareness from the autonomic neuropathy is very common in these patients. And if they cannot feel a low sugar in the 70s or lower, then they are at increased risk for hypoglycemic unawareness and complications. If it's a young female, I want to know if she wants to get pregnant, what, and if especially if the diabetes are uncontrolled, then we will actually recommend against the pregnancy. Uncontrolled diabetes can lead to pregnancy loss and complications during pregnancy. So these are the things we will screen for the patient. Next slide, please. I think physical examination is important. Again, it's a time constraint. We all have problems with that. So I quickly want to look at their blood pressure that the nurses have recorded, their BMI. And if they are reporting that they feel dizzy on standing up, then it's always a good idea to do a orthostatic blood pressure. Have them stand up for 1 minute and check the blood pressure again. Make sure that they are not dropping. And if so, then this could be autonomic neuropathy from diabetes, or could be the medication, so we can make adjustments. We don't want them to be falling down. Thyroid palpation, only if you see something on inspection, then you can do a thyroid palpation, or if they're having any problems. Importantly, we need to see their skin and see if they have any dark pigmentation, any acanthosis nigricans, which is a sign of insulin resistance. If the patient is on insulin, it's always a good idea to check where they're injecting and feel the area, because sometimes they have scar tissue formation there, and they are not then they keep injecting the scar tissue, and the insulin absorption is just not happening. You keep cranking up the insulin and they are not absorbing it. This is a common issue problem that I see. And then if you ask them to rotate the injection, this will actually improve and they will not need. And sometimes this is the only reason that they are having so much fluctuation. So that's something that always should be done, especially for a new patient, and annually as well. Examination, quickly, I want to look at their feet. I want to see if they have callus formation, if they have dryness of the skin, and if they have deformity. And I will show you some pictures. What kind of a foot is more at risk for developing ulcers and amputations. So that's what I quickly want to visualize. If they have a peripheral arterial disease, they have poor circulation, they're losing hair, pedal pulses are poor, then we can check for ABIs, or ankle brachial index. Otherwise, pedal pulses is a good screening test, and this is all I will recommend doing on the first visit. And of course, we want to check the temperature sensation and tuning fork. 128 hertz, I want to make sure that they can feel it. Most diabetics, after a few years, will have problems with neuropathy, but this will be mild neuropathy. But is it increasing and progressing and causing problems is what I'm looking for when we are seeing these patients. Next slide, please. So foot exam, and this is important, especially during the first visit. So this exam is divided into 4 major components. Number 1, just visualization. You look at the skin. You're looking to see the color of the skin, the dryness, if there's any cracking of the skin. Diabetes affect the nervous system, autonomic nervous system. Autonomic nervous system controls sweating. If the sweating is not happening, then this will lead to the dryness of the feet, and eventually cracking, and cracking will lead to ulcers and the infection. Cellulitis is extremely common for the same reason. So if I just see cracking, I will tell them to examine their feet, put some cream at least 3 nights a week, just to prevent the dryness, more so in the winter months. Sweating, for the same reason. Do we see dryness? Are there any ulcers on exam? And there are any blisters and calluses on inspection? Musculoskeletal, I want to see what the toes actually look like. Are they prominent at the metatarsal heads? And again, I have some pictures I will show you on the next slide. And muscle wasting. So I think when we look at the next slide, I'll explain this in more detail. Neurological examination, we are checking for neuropathy, 128 hertz tuning fork. I want to put it on the tip of the great toe, and I will ask them to tell me when they stop feeling it. And when they cannot feel it anymore, I'll put it maybe up on the shin area and see if they can still feel it. So that means this is the peripheral, distal peripheral sensory neuropathy. The furthest the area is away from the brain, the first it will be affected by the diabetic neuropathy. And it goes in glove and stocking pattern, so it slowly increases. It kind of goes up over with a period of time. Ankle reflexes, if their ankle reflexes are affected, that can also happen with neuropathy because it affects the nervous system. Pulses, we already talked about the dorsalis pedis and the posterior tibialis pulse needs to be checked and see if this is weak, absent, or 2 plus, which is the normal pulsation with the is present. Next slide, please. So this is these are some of the things that you will see, and these are the worrisome things. So the first picture here, you see the dark pigmentation around the neck area. This is the neck of the patient. Sometimes you will also see it as I've seen in the second picture around here. So in the axilla and armpit areas, this is the dark pigmentation. And here in the third picture, you see a lot of skin tags developing around the neck area. These all three are signs of insulin resistance. Polycystic ovaries can also cause it, and this is because insulin is like a growth hormone and it will cause proliferation of the skin cells, and that's why it looks dark, velvety, kind of smooth to feel, velvety in texture. And the same thing, because insulin is a growth hormone, and if there is resistance, the body is trying to make more and more insulin. That's why they end up developing these areas around the neck area, armpit, and also around the neck and the chin areas where they mostly develop. So I mentioned initially the joint problems that can happen with diabetes. Now this is called the prayer sign, and if you ask your diabetics to make to close their hands like this, most of them, especially those that have diabetes for a long time, will not able to do it. And in fact, they will be like this. So you will see some gap, and that is again because the diabetes is affecting the joints and the tendons that surround the joints. That's the tendinopathy is common with diabetes. So as you can see, this can progress over a period of time to some hand deformities. And that's why the Dupuytren's contracture, which is basically the contracture of the hand, is common with diabetics. And if they have this, then this can limit their ability to inject. Frozen shoulder, for example, the stiffness of the shoulder, the adhesive capsulitis is for the same reason. Tendinopathy is extremely common with diabetics. So if you're worried about it, you can have them lift their hands and see if they can move shoulders in all directions. The last two pictures are about the lipodystrophy. So this is scarring from multiple repeated injections. And if you can see here, if they have it, then ask them to avoid these areas completely. Go on the left, on the right, but do not inject. Most patients have a favorite spot that they like to inject. But if you keep injecting a scar tissue, then there is no guarantee that you are absorbing the insulin or not. And sometimes, in my view, my opinion, this alone contributes to all the fluctuations. Sometimes the same insulin dose is causing them to have hypoglycemia. Sometimes the blood sugars are high. So look into that very carefully. Next slide. So for exam, again, you're looking at the patient and you're looking at their feet. Again, the first thing I said was to look if there is any dryness, ulceration. So if that's the only thing you're seeing, you ask them to put some cream on it. But this is worrisome if I see this, because if you see here the metatarsal heads right here, these are more dominant. This means that the joint deformity is already taking place. The patient has lost some arches already, and these areas, for example here, this will lead to ulceration by excessive pressure formation. So these patients, if you see this, then these patients need to see a podiatrist. They need to wear appropriate footwear with the wide, wide shoes that are not pressing on it. and take the shoes off if they are not, they're not in their home. They should not wear these kind of shoes, because this will actually make it worse. So this is a worrisome thing, and this is called the guttering basically. So you see here again, this is because the tendons are getting going in contracture, and you can see these tendons very prominently. So I look at the tendons, I look at the metatarsal heads, and this hair, the loss of arches and the curving of the foot. And if I see this, I will ask them to take better care of the feet and see a podiatrist. Next slide, please.
I have a question. Are you talking about hammer toes?
Yes, sir. Hammer toes and the clawing basically. The tendons are actually flexing, and the metatarsal head, so hammer toes basically. Yes, you're right.
Okay, okay.
All right. So lab evaluation, again, you're seeing the patient, and the first visit, we want to make sure, besides doing the A1C, which we need to repeat every 3 months, we want to look at their lipid profile to see if they will benefit. Like the patient I discussed initially, I mean, he was not on a statin. So I want to know if he will benefit and which intensity statin. Liver function test, because of the fatty liver is very common with diabetics, so I want to check that. Urine spot, albumin and creatinine. We want to check the GFR and the creatinine. Thyroid, especially in type 1 patients. Vitamin B12 if they are on metformin for a long time. If they are on an ACE inhibitor, then we need to look at their potassium and also renal function. So these are some of the labs that we will do commonly when we see these patients. Next slide, please. Now we're coming to the plan. We have discussed about what to look for, what to order. So set an A1C goal with the patient, and this is the glucose target actually. This is very important. If the patient's blood sugars are running in the 300s, and you set a target of 100 for that patient, immediately you're setting this patient up for disaster. Relative hypoglycemia is extremely common. These patients will feel low blood sugars even in the 180s, if they drop less than 180. So if I see a patient and the blood sugars are in the 300, initially for the first 2 weeks, my target is on a blood sugar of 180. I do not want the blood sugars dropping less than 180. And I'll warn the patient that even if you are in the 120s, you will get some symptoms. So we want to avoid it. You send us the blood sugar, and then we will make the adjustment. So we will go slow. The patients get acclimatized to a blood sugar of 300. If you drop it, the nervous system will start sending signals, and the epinephrine, norepinephrine, and the stress hormones will be released even with the blood sugar is normal. So relative hypoglycemia is extremely common. And patient needs to know this, that eventually we'll bring it down, but initially upfront, we are not shooting for ideal numbers later down the road. Hypertension, we want to see, again, we do not treat one number, one high blood pressure. We want to see if this was white coat hypertension, how are they doing at home, what kind of numbers they're running at home. Again, I want to incorporate new members into their treatment plan. Dietitian, for example, ophthalmologists, dentists, if they have a bad dentition, and medical nutritional therapists. And provide them with diabetes education so that they can learn and they can know more about the disease, because this is, once you have it, unless you go for bariatric surgery, you're going to have it for the rest of your life. So they need to be educated. All right, next slide. We mentioned this. The whole idea of treating diabetes is to make them live longer and healthier. And some of the things that can really cause damage in these patients is the atherosclerotic cardiovascular disease. So stroke, heart attack, peripheral vascular disease, we want to get that information. We want to see what other risk factors they have, high blood pressure, high cholesterol, which can also increase the risk along with diabetes. And then the staging for the kidney disease. That's why we're getting a BMP. Next slide. All right. The plan, lifestyle. I mean, we know this patient needs to, if the patient is not exercising, has sedentary lifestyle, we need to change that. We need to discuss the pharmacology. So the second, after lifestyle, is the medication. We want to choose a medication that fits into our plan. For example, If the patient is obese, we want to give them a medication that will not only help their diabetes, but also help them lose some weight so that the insulin resistance can improve over a period of time. So that is another thing we need to look at. Dietitian, diabetes educator, devices, if they are covered by insurance. I understand that's a major limitation. They want blood sugars done often, and but we want to make it, give them some hope that if we can offer them some tools like a continuous glucose monitoring system, especially if they are on injections, get it approved. We can write a letter to the insurance, and sometimes we can get lucky and get it covered for them. So give them hope, but initially they need to do it themselves. They need to check the blood sugar, especially while we are making changes. Next slide. Click a couple of times more, please. All right. So this was the patient that I initially discussed. Just to recap, the 5-year history, diabetes, and so now the things in the red is the information that we gathered after talking to him. So he has sedentary lifestyle. His family history is his father had an MI at the age of 55. He has never received the Pneumovax vaccine. His wife reports that he snores a lot at night. And besides the metformin and the glimepiride, he had not used any other medication. And if you see on the first on the visit, his blood pressure was high in spite of taking the lisinopril. And I think this is covered. So the patient has never seen an eye doctor, and on exam he has some dryness on the feet, but no hammering of the toes and loss of the arches that is seen. So for this patient, he's obese. He's not morbidly obese. His BMI is greater than 35. So that's something that we need to address. His lifestyle is something that needs to be addressed. Vaccination is something that we need to look at. Sleep apnea, maybe his tiredness and some of the things that he cannot exercise is related to sleep apnea. So eventually, weight loss will help sleep apnea, and sleep study may help as well. So those are some of the target areas that we have. He has never seen a dietitian, so giving him more information will help. And then on top of these 2 medications, if I give him or if we start him on once a week GLP, your medications like Trulicity, like Bydureon or Ozempic, this will help us target most of the areas: weight loss, appetite suppression, bringing the A1C down, cardiovascular protection. For primary prevention, because his father had an MI at a young age. I want to know what his cholesterol profile is. And if most diabetics should be on a statin between the ages of 40 to 75, but if his cholesterol is high and his 10-year risk is high, then he will need a high intensity or a moderate intensity. Otherwise, we can just get away with a low intensity. So I want to look at his lipid profile as well. So yeah, that is the kind of plan after talking to him we will come up with. Next slide. All right, so that was the last slide, and we will talk about the metabolic health in the next time.
That was excellent and super informative, Doctor. Thank you so much. Before we jump into some questions, I saw we had a few more people hopping onto the session, which is excellent. So I wanted to introduce some of them. Donna, would you like to introduce yourself? You may be muted there. We can loop back around as well if the connection is poor. Dr. Paliwal, would you like to introduce yourself?
Yeah, this is Dr. Himanshu Paliwal. I'm a family medicine working at Fairmont Clinic.
Awesome, thank you. And Branya, would you like to introduce yourself? Anyone having some audio issues, feel free to use the chat feature as well. All right, so we did get a question in from the chat on the side here. So the question is there a formula for calculating target A1C?
What do you mean by target A1C? Formula, and I'll be happy. But what what is the meaning of target A1C?
Let's see, I think she's chatting it in real quick. Based on age?
As a rough rule, we normally oh, I see. Got it. Yes, absolutely. Yeah. That's a common thing that we are asked, and this is a very important. If suppose you have a 85 being in the nursing home, demented, then the A1C target, according to American Diabetes Association, is around 8 to 8.5. Because again, avoid low blood sugar. So we can let the blood
Dr. Heder, I think the connection is breaking up a little bit on our end here. It keeps going in and out. If you're still able to hear us, you can chat us as well.
I can, based on.
Are you able to hear us on your?
I can hear you. Yeah, I can hear you. Can you?
Yeah, it sounds like the connection's slowly coming back over here. I apologize about that. So it was really difficult to hear the answer for the.
I can repeat myself.
Thank you. Thank you so
You're
much.
welcome. You're welcome. So at extremes of age, so meaning if the patient is more than 85 or has poor life expectancy, demented, in a nursing home, then A1C target is around 8 to 8.5. We do not want a low blood sugar. We don't want the numbers to be very high because it will lead to complications like bed sores and urinary tract infections. But we don't want a target of 6.5 and then having hypoglycemias in that situation. Ideally, in a normal individual who is recently diagnosed, we want the A1C as close to 6.5 as possible, because that will prevent the complications. More so, the target is strict initially in the first few years after the diagnosis, because then we can prevent the complications. Patients who are well controlled initially in the first 5 to 10 years of diagnosis, their risk of developing eye damage, vision damage, body forms a memory called the metabolic memory. So early in the case, in the course of the disease, I want to be aggressive. For young type 1, I want to be aggressive. Type 2, young patient, good life expectancy, want to be aggressive. And then as the age progresses, they already have complications. We will still try and do our best, but the main target is to prevent hypoglycemia situation.
Excellent. Thank you so much. And thanks for repeating that as well. Any other thoughts, comments, questions? It seems to be that we all have some audio and technical issues, I think, from the storm last night, but chat them in. If you think of them after the fact as well, you can email me.
This is Dr. Paliwal. I have a question. I have come across situations where, like, when we are checking diabetes, some of the patients go up beyond 6.5, like 1 or 2 times. And then over the time, their diabetes is either too much good controlled or they remains less than 6.5 even without medication. Okay, so I have like this kind of few patients. Now, should we really put them into pre-diabetes and monitor them, or should we really be more aggressive with them and keep putting them on medication for diabetes?
Right, that's a good question. So we diagnose diabetes based on A1C by 2 different A1Cs done at least 24 hours apart. because there are some lab variations, there are some assay variations. So if suppose you have a patient whose A1C is 6.6 one day, and then you repeat it in a week and it's now 6.4. So that is not diabetes, that's still pre-diabetes. So you need more than 6.5 two A1Cs done together. Now you can certainly do a post-meal, post-prandial glucose tolerance test or a fasting blood sugar if you want to get that information. But sometimes if the patient has lost weight and so they may be 6.8, but now after weight loss in 3 months or watching their diet, they are in a pre-diabetes range. So in that situation, if the patient is already successful in losing weight and controlling their diabetes, they should continue with that. The only way you can prevent progression of pre-diabetes, 5.7 to 6.4 A1C into diabetes, is through weight loss, which is 5% of the weight loss, or with medications. So if you have a motivated patient who is trying his or her best and is successful, then there is no need to put the medications. But if you know a patient whose A1C is 6.4, who is not going to change, or has a lifestyle that is difficult to incorporate the exercise, then it's a good idea to try with the lifestyle, but add a medication and continue the medication, even if the A1C comes down. Because if you stop the medication, more than likely the patient will become, A1C is just going to go up with the period of time.
Okay, thank you.
You're welcome.
Thank you so much, Dr. Hutter. Any other comments or questions? Branya, thank you for chatting in as well. We're Branya Tucker, NP from Fairmont MBA. All right. Well, thank you so much, Dr. Hutter, for that excellent didactic. I just have 2 brief announcements before we part ways. So our next session will be on July 22nd, and Dr. Hutter will be continuing his didactic on metabolic health and diabetes. And the other announcement is that Caitlin is no longer with us, and we're really sad about that, but she has taken a new position with WV Medicine. So, all right. Well, if there are any other questions after the fact, feel free to email me. I'll make sure to have them addressed and sent back to you, and we'll see you all next time. Thank you.
Thank you.